Why do you think the world is so excited about AI?
Most of what we call AI is really very turbocharged statistical learning.
So why do you think healthcare is such an important frontier when it comes to AI intersection?
The birth of AI really starts with statistics. As data became available, you could ask deeper questions.
Artificial intelligence, machine learning, deep learning, then we talk about generative AI. What is all this, and if you can describe in brief,
Yeah.
what are these for a medical person?
With machine learning models, statistical models, because they were model 1st results later, the models were credible, and the people that designed the models also designed uncertainty quantification mechanisms to ask what's the play in your prediction. Millions of pictures of cats and dogs on the internet, and you could synthesize a brand new picture of a dog that has not been, whose picture doesn't exist on the internet. You can make a brand new picture. That's generative AI.
Welcome to OncoFlex podcast. Today, our topic of discussion is going to be artificial intelligence in healthcare, and we have with us Dr. Aravind Rao. He is a professor in computational medicine, bioinformatics, and professor in radiation oncology at the University of Michigan, Ann Arbor. Welcome to our podcast.
Thank you for having me. Thank you very much.
Why do you think the world is so excited about AI? And, how is it, changed the perspective in the last decade?
Firstly, thank you for having me. I'm really appreciative of your kind invitation. It's really a pleasure to speak to you and the group today. So, regarding the question about AI, I think what's happened is that um, most of what we call AI is really very turbocharged statistical learning. Right, the concept of statistics have always been there for many years, but the power to be able to do compute at scale with GPU technology, with large amounts of data, have really made those concepts come alive. So what's happened is it's almost like a singularity moment where all the circumstances came together, and then finally the promise of AI could be delivered. So we had lots of data on one side, lots of hospital systems interested to think about AI for their patients. The compute capabilities become available, technologies become accessible to a point that you can actually use them fluidly to build your own kind of AI system. So all these is, I think, what has led to the current energy and enthusiasm around AI.
Nice. So if you have to share with us your journey from the point where AI can do so many things in medicine, you could have had a point like that to where you are today. How would you?
Yeah, so I'm very grateful to my mentors through graduate school, and also when I was an undergraduate in RV College, I had a mentor, Professor A.G. Ramakrishnan, in IISc. They really helped me think about how I could use my engineering skills for areas outside of just pure engineering. They were working on aspects of optical recognition, character recognition, OCR. They were working on aspects of medical imaging. At that time, it occurred to me that the things that we learn in college are actually have real world examples, real world applications. It's not just to live in the textbook. And then when I went to graduate school, I had the opportunity to explore biomedical data as part of a data mining class. Again, at the time, it was very unusual. And around the same time, the human genome had just been sequenced.
Right.
Okay.
Data was becoming available, and people were asking this question. But we are lucky now to have all this data. How do we make sense of it? So and then the good part was departments and universities became extremely friendly to thinking about cross collaborations. So computer scientists worked in genetics department, geneticists worked with people in mathematics, etc. And so that culture came around that we are incomplete if we don't work together.
Right.
And I think the biggest part for me was the realization that these skills have a much bigger landscape of potential application than what I had initially assumed. It was just an assumption problem from my perspective. Because as I knew it, engineers in my work would go to build better communication devices, you know, hardware chips, those kinds of things. Suddenly now we realize that those skills are not restricted.
Correct.
As long as you have the right mentors, the right colleagues to discuss with, you can really bring your skills to anything. So that was the aha moment for me.
Right.
Okay.
And I think when that happened, I got working with some people who said, we have medical data. How can this actually can help patients? So I've always mentioned that I always wanted to be a doctor, but I didn't have the grades to get in or whatever it was. But the end result was that this internal need to be of service to medicine was also a part of this. And so it just happened to converge in a very nice way. So I'm very grateful to God for that.
Very nice. So you spoke about, the GPUs, the high capacity computational, methodologies which have probably leapfrogged AI to the forefront right now. And do you think these are the only aspects, probably in the past 3 to 5 years, where the adoption of AI into the mainstream healthcare has made it possible, or what are the other aspects from your,
Yeah.
engineering perspective
Yeah,
that
I
it's going to
think,
be like?
yeah, something I keep coming back to is that education has had a very big part to play in this, right? For example, the general sensitivity of the audience, of the ecosystem, went up to say, we have a data problem. We have lots of data, and we need to have creative solutions to make sense of it. Who do we need to bring to the boardroom, so to speak, to actually get maximum value of this data for the benefit of what we do, patients wise and healthcare management wise? I think that sensitivity is really important, because then we began to say who's missing in the picture. Doctors realized they needed IT, they needed computer science people, they needed AI engineers, actual AI engineers, and it's very easy to have a proof of concept idea. But to take it all the way to implementation is a very different ask. And so those organizations that were able to bring it to routine deployment had a very different sort of vision. They said that, well, if you're a corporate hospital system, you have so many units, so many nodes, you're geographically in very, very different places. They have different facilities, different demographics. How do you use this sum total of information in a credible way to do what is right? I think that's where the vision came. Do what's right for our patients. And the moment you go with that vision, the bricks become apparent. What's missing, what needs to go in, those kinds of things. So I think the fact that all this came together at that time, and then IT people also realized that healthcare is a very important space, right? ERP companies realized that workflow optimization is a very big deal. Handling lots of image data, labs, EHR, all became important questions. And so I think that some total, cross-fertilization of events is what led to, I think, all that we are seeing with AI right now.
Perfect.
So why do you think healthcare is such an important frontier when it comes to AI intersection?
Yeah, I think it's a great question. I think it goes back to something I think we talk about, the UN's Sustainable Development Goals, SDG. And I think the fundamental, understanding is we want to do whatever we can to improve the condition of society. And healthcare is a very important component of that. We have examples across the globe ranging from infectious disease to cancer to metabolic disease, cardiovascular disease, all of which presents in very different ways, in different demographics, and in very different lifestyle conditions. The complexity is too much unless we can have help. And AI is just, in my mind, I use the word AI extremely liberally.
Right.
I don't mean anything technologically finessed about it. To me, it's just a word that is, I think we'll talk a little bit more about this, but to me, it's a sum total word that encompasses the ability to do mathematics, data science, visualization, reasoning over data, cognitive science, those kinds of things. And so the fact that we can do all of this integratively necessitates that we build AI systems to cater to the improvement of human health in general. And now the narrative again is changing to, can we keep people on the healthy path? So what will it take to stay healthy, to stay well? Right? And again, there's a lot of interventional aspects that have to happen because of that. So both for treatment intent or for lifestyle maintenance, I think we need tools from here. So I think that's why we are seeing all this energy.
From a doctor's perspective, when we read in the newspapers, or probably when we read articles pertinent to artificial intelligence, we read words like artificial intelligence, machine learning, deep learning. Then we talk about generative AI. what is all this, and if you can describe in brief,
Yeah.
what are these for a medical person?
Okay, so I'll attempt something along that line, which is that I guess in my mind at least, I'm trained as a statistician also. So to me, I think the birth of AI really starts with statistics,
Okay.
right? So good statistics involved giving guarantees to about how well you can predict something, given a certain amount of data, making justifications about that.
Right.
As data became available, you could ask deeper questions. And then there was a period over which the engineers said, well, how do we use the physics of the data to engineer good features that we can then use to make better predictive models? Then came along the situation that is said, well, the ability to do feature engineering requires a very intense conversation between the domain experts and the AI or the algorithm developers, right? And maybe after a lot of work, eventually you'll get to a point of finding some key variables.
Correct.
What if that was not possible? What if data could instead become a substitute where you don't have to actually engineer the features, but you can learn the mapping between the data and the thing you care about directly from a lot of data? That's where deep learning came.
Okay.
So machine learning was sort of has always been the precursor, where you basically try to program rules or you learn the rules from the data. Or deep learning, you could now turbocharge that by saying, if I have lots of data, I can have the algorithm learn the features directly without necessarily having to engineer them. That was a very big benefit.
Isn't that there an uncertainty when it comes to deep learning then? Because when you say machine learning,
Yes.
you know what is happening.
Yes.
In deep learning, you assume it's happening.
Very well put. So with machine learning models, statistical models, because they were model first, results later, the models were credible, and the people that designed the models also designed uncertainty quantification mechanisms to ask what's the play in your prediction.
Right.
The moment you defer to the amount of data and say, I'm going to learn whatever I can, that's where the problem occurs, is you don't know with what precision you're learning whatever you can. So that's deep learning. Generative AI is just, I think, it's not deep, it is in the family of deep learning models, there are two kinds of models. And you can even think of it in more classical terms. One is clustering, one is classification. In classification, you say, let's say I have three different kinds of fruit from the grocery store. Two of them are green, and one of them is red.
Okay.
If I only looked at the color, I would put the two green fruits, whatever be their shape, into the same bucket, and the red fruit into a different bucket. If I told you that the first one's an apple, one's a green apple, one's a green banana, and one's a red apple, you could then say I can reclassify the exact same data, where I put the apples together and the bananas separately. The moment I had more information, I could make a more nuanced decision. That's clustering versus classification. The same story applies in deep learning. In deep learning, your classification is what you're mostly doing. You're trying to discriminate different things. But clustering is trying to see whatever you have in your available data, how do you learn some patterns underlying it? If you're lucky, you learn some physics. This is what generative AI tries to do. It tries to generate models that capture the complexity of what you're observing.
Right.
So now you can see, for example, millions of pictures of cats and dogs on the internet, and you could synthesize a brand new picture of a dog that has not been, whose picture doesn't exist on the internet. You can make a brand new picture.
Correct.
That's generative AI.
Okay.
Right? You're generating something that exhibits the same statistical properties as what you learned. But if you didn't have enough data to begin with, you would not learn a very good statistical model, which is why medicine is complicated. Because medicine is about pathology and what can and treatment is about what went wrong.
Correct.
The instances of what goes wrong is a very small subset compared to what normally happens. That's why that's why we need to have a human AI hybrid, because otherwise only human can flag what is genuinely abnormal. And by definition, because abnormal, it's so rare to encounter in general that you will never get enough data to be able to learn a good. Therein lies that conflict between what deep learning can do in general versus what it can do for health.
Interesting.
Great. So, quoting from a personal example. So, back then when I was in my MBBS, right, if I had to write an article, So I used to go to Google certainly to find out references which are credible. I used to have an idea. I used to plot that down, get the references, and then write an article out.
Yeah.
Lot of creativity out there, thinking out there. Now, if I have to do the same using any of the available AI, in a click of a button, by feeding what I want, giving the right prompts, it may be able to do a better job than me.
Okay.
When I used Google, I still use some form of data collection that it could put it across to people like me.
Yeah.
But my creativity still existed there. When I did this, it is doing a smarter work. Probably I'm verifying what it has done is right also by referring the sources which it is quoting. But my creativity is gone there. How do you see this? Is AI a boon or a threat?
Yeah, it's a great question. I think it's all about context, right? I think what I like to think about is that you see, when there was once a time in the 60s when calculators were not allowed in schools. And they said, well, if you take calculators away from the students, they'll be able to do basic mathematics in their head, right? But what happened? Really, what happened, right? Our ability to do more complicated things went down. The questions in our exams changed. Instead of saying 2 plus 2, now it's just an operation that you use in your overall problem. 2 plus 2 is just a part of that solution. It is not the thing you are looking for. So I think it's a beacon call to us as a community to say, maybe it's trying to improve our quality of what we evaluate in our students, rather than saying that they are not allowed to use certain tools. Because these tools are there, there'll always be a plus and a negative. But if you want to use it judiciously, the idea would be, can we now aim more audacious problems? Can we make our problems harder? Can we work on more real world situations where these things continue to be tools? And you're not evaluating the essay, you're evaluating the essay in the context of a bigger argument. Right? Essay is just a part of it. And so I feel that perhaps it's, in my perspective as an educator, I feel it's probably just a good time to rethink who we are as educators and teachers, and maybe help our students evolve as well, to use these tools for their own efficiencies.
So, recently I was reading an article. It seems in China, they have a complete AI hospital where there is usage of humanoids, there's a lot of automation, and even the clinical decision support systems. Probably an advanced version of IBM Watson, maybe a very, very advanced version of IBM Watson. So it's also trying to make clinical decisions. Okay, it's trying to replicate a doctor's decision making as well. Do you think the advancements in this is going to impact doctors' decision making in probably choosing the appropriate treatments for our patients without actual thinking and just going on the chatbots like ChatGPT or Perplexity AI or DeepSeek?
Yeah, it's a great question. I think I personally feel that medicine is a lot more nuanced than that. It's not about just answering questions from a book. And the cases that we encounter have components of patient history. What is proffered, what is elicited, the iterative questions, that process that we follow as human beings, not necessarily even as doctors. And then using laboratory tests at the right time to be able to extract the information that you need to complete the picture about the patient's unique situation. While all those things might eventually be possible to systematize, it's very different from trying to automate. Automate means no human involved. Systematize means to involve the human in a very important, significant way as a thought part, as a trust part, to ensure that there's a proper handoff between what the model can learn about the patient, what the doctor has to say, and what that collaboration will eventually do to help the patient better than either one independently. So I'm a big believer that, as an augmenter of the process, AI is here to stay. But the fact that you can completely circumvent the need for a medical professional at the level of a doctor, I think tends to oversimplify the quality of nuance and knowledge that a doctor brings to the table.
One other thing is the emotional connect between a human, interaction is way, way, more than what a machine can give, and also the empathy is where the factors are much, much more than the machine.
Yeah, and I think one more thing, I just came from a meeting this morning, and a gentleman there was mentioning that as a doctor, he has, I mean, AI can treat a tumor, but who treats the patient? Who treats the family of the patient?
Right.
Who treats that ecosystem that is required for the patient to make recovery from where they started to where they have to be? That process requires deep counseling, requires a trusted, confidant collaborator. And I think some of these aspects are probably possible to, you can break them up into routine tasks and non-routine tasks. For routine tasks, maybe AI can help improve the efficiency of the doctor. But in the end, you still need a doctor to have that face-to-face conversation.
But the buzzword AI sells to the public.
Yeah.
Okay. It is like artificial intelligence is like a trust factor.
Yeah.
So for the public, it seems okay, fine, there is artificial intelligence. So there is some kind of a trust which is being built more than human. So it's like validating, human intelligence.
Yeah.
When you integrate artificial intelligence into your work culture, either in medicine or either with respect to the regular working scenarios.
Yeah.
And especially, I think that is very relevant to the Indian scenario at present.
Absolutely. I think you bring such an important dimension. One is that the jump from where we are to AI ready, I think is a very big jump. And to just be very fair, it's like saying, I don't become an automobile engineer by reading the cars section of a newspaper. It requires me to go to engineering college, learn mechanical engineering, especially in automotive technologies. It's a 6-year path. But a lot of people talk about cars. It doesn't make them automobile engineers, right? And there is the path that and then one thing important to remember is not for anybody's fault in particular, but it's very easy to dwell on the extremes, right? What worked very well, what didn't work. What we need to cultivate in the community is a sense of measured and cautious optimism. There's optimism for sure,
Yeah.
but it has to be cautious because it has to be grounded in the actual capability of the AI. Now, what do I mean by that? If you were to query AI or an engine like ChatGPT to seek medical help, which I think people do,
Yeah.
is what's the credibility of that? Has it been vetted? Has it been verified? Right? What data source is it drawing from to make that prediction? And I'm just putting as a challenge to anybody who's listening to this. Have you ever heard AI or the ChatGPT engine that you use, be it ChatGPT? Again, nothing against ChatGPT. I mean, ChatGPT, Grok, Perplexity, Claude, whatever it is. Have you ever heard these 3 magic words out of the ChatGPT, which is, I don't know? It always has an answer, right? And just because it has an answer and it sounds like it's human, does it actually make that human? There are some aspects that we just take for granted. And then we have to remember that when ChatGPT uses the words thinking, thinking computationally as what they mean is very different from the way we do thinking as humans. Reasoning is very different between what it calls reasoning and what we call reasoning. It's a very different That's why there's a lot of tension in the cognition community because they're using these words a little bit irresponsibly. So it's very important to perhaps take a step back and calibrate. Are these things actually what is happening, or is it just buzzwords they are using to make it comfortable for us? Right?
Is it the time that it takes to pull out a reasonable data from its
That's one component. But when you're making prediction over multiple sources of evidence, it requires you to basically propagate probabilities, right, of different events happening,
right,
and then you vote on them. But the way predictions happen is that you can't. It's not very easy to go from A to B. A can go to B, can go to C, can go to D. It requires human abilities and questioning capabilities to say which is the most likely path. Sometimes there's not a single path. There can be multiple paths. So we have, as humans, we've cultivated over centuries this concept of epistemic humility, where we say it's okay to say I don't know.
Yeah.
Because the moment you say I don't know, I become a student for a question that I can then ask a mentor or an expert. But the moment an agent says, ChatGPT agent says, I know everything, and I can give you information on something as obscure as rocket science or myocardial infarction, right? That breadth is just too much for it to be able to even be sure of what. So one thing I want to always point out is it's easy to say what you know, but it's harder to say what you don't know and why you don't. As long as those things are not clarified, there's a risk of not using it in the right way. And I want to make one more point, which is that our it's unfortunate, but we seem to be getting our knowledge of AI from popular tabloid magazines and newspapers, not from a technical journal. It's like saying, if I talk to you about medicine, I'm sure you don't go to medical school reading a newspaper. You have some really, really big textbooks that you study that are deep dives into these, that talk about these things in very, very great detail. It's like saying, how can I talk about immunotherapy if I don't study a Lancet and if I'm reading some new normal newspaper? I think the same thing has happening with AI. Is people, because these companies and these newspapers, I think they mean well, they want to educate, but in their effort to educate, they're oversimplifying.
So what happens when we prompt it, right? If I say that you give this source of information only from validated sources.
Right. So this is a version of what is called retrieval augmented generation, RAG.
Right.
And you can do that. But then you have to be very careful that your seeding of the knowledge corpus is restricted to exactly what we specify. But more importantly, you should try to prompt it in a way to say, based on what I've given you as seed information, when you give me an output, give me a 3-color format output, which is, if you're very certain, give it to me in green color. If you are somewhat certain, give it to me in yellow color. If it's not you're completely uncertain, give it to me in red color. So at least I know.
You can do that.
You can do that.
Yeah.
Right. So now you can say that. Right. And then it will basically spit out information that says, okay, this part I'm very confident, this part I'm somewhat confident, this part I'm not at all confident. The good part is you can now use the information to go and fill the holes on whatever the algorithm is uncertain about with your own due diligence. So that's possible.
I mean, that's exciting. So you spoke about, rocket science to the MI as well.
Yeah.
So when you're talking about MI, okay, myocardial infarction or heart attack in simple words, you give a proper prompt. Okay. Don't you think the data is going to be taken from the web, from whatever data sources the system is having access to, and it's going to get to the genuine color coding, whatever prompts you've given, and accordingly it's going to give you the right information. Correct?
Yeah.
And the same thing with respect to the rocket science as well.
Right.
Don't you think whatever is available in the web, that's going to be like aligned in a way where you're going to get genuine information, whatever is going to be there on the web? And now all the textbooks are there, all the resources are available on the internet.
Yeah.
So don't you think that kind of capabilities are there with our systems available?
So it's interesting you say that, because I don't think if you're going to delve deep into the algorithmics of the decision-making process, yes, it can help them.
Okay.
But for example, this realization of a doctor that, okay, why am I seeing this? Is it because of their lifestyle choices? Are they from a particular demographic and eat a certain kind of food that makes them more likely to exhibit this sort of, behavior, right? What is it attributable to? So as a doctor, you're able to now be a generalist.
Correct.
In terms of integrating different sources of data and saying the ChatGPT for nutrition gave me this signal. The ChatGPT for imaging gave me this signal. The ChatGPT for genetics gave me this third signal. But I, as a human, have to put these pieces together to say, what is the most likely explanation for this disease presentation and what can I do to help the patient? I think that's the part. So once you know what you want to do, then you can go deep with the GPT.
So it's very important to know what you want.
What you want.
That's the key here. It's
Right.
very important to know what
Yes.
what you want, and you also need to have a strategy to verify
Right.
whether what it is telling you is credible.
Correct. Absolutely. And see, think about it, the way medical school is structured, you study all your basic courses, all these courses individually in the beginning. But then what you study in the next 2-3 years is putting it all together.
Correct.
That is doctoring. If it was not the way, everybody who finished 2 years of medical school would start to practice medicine. That's not the way it works. So the integration, the knowing whom to ask what question, what lab to get from whom, which unit, before you can make a decision. And participating in the tumor board, for example, we're talking about cancer.
Correct.
The fact that all these people are in the same room discussing all their perspectives, and then making a decision for the patient's benefit. I think that conversation,
Yeah, that finesse.
and that nuance, that context is really, really important. I don't think it's that easy to create a prompt for that. It might change. I might likely be wrong, but I still feel that I think the ability of humans to reason integratively is something that we have cultivated quite well. I think something that we just have to learn to use these tools for their best intent.
True, true. Well said. So we often talk about Watson in oncology, right, as a failure model, quoted as a widespread example. So what is your perspective of it?
Yeah, I think the enthusiasm and the energy around it was genuine. I think they really wanted to help patients. But I think at some place there was a incorrect assessment of the complexity of healthcare delivery. What I mean by that is that while Watson did very well or did very well on the Jeopardy sort of style model, I think the same thing is actually a very important dovetail, because even today we talk about ChatGPT, getting very high marks on USMLE board exams, IIT JEE. What one has to remember in all these situations, the question that is presented to the algorithm is self-contained. It contains all the information required to get to the answer. But real life is not like that.
Correct.
It's very iterative in its process.
That's right.
You only get pieces of questions and pieces of answers. You have to put them all together in your mind as a doctor or an engineer. So I feel that their intent was very honorable, but I think, like I said, they underestimate the complexity of how decisions are made in oncology. And I guess and also there was no calibration of uncertainty of the model.
Right.
The model couldn't say, or was never trained to say, here's what I don't know about what I don't know.
So if today you being a computational scientist are given a chance to go and modify something of the Watson model, what would that be?
I think there will be two components. One is we are now in a very different time in technology, because now we can connect Watson not just to its own engine, it can be connected to other engines from other companies as well. So the ability to cross-talk between agents is going to be critical.
Wow.
Number one. Because the emergent failure that can happen when two agents start colluding is a very different dynamic than individual agent.
So
that was exactly our next.
So that's like ChatGPT, Perplexity, AI, Grok
talking to
all talking together.
Watson.
So it's like discussion among
exactly agents, right? So what does a committee look like in that kind of situation? And then just like in a committee, you could have a situation where maybe two people in the committee collude to drive dynamics in a certain way. Could agents learn to collude?
No.
It's already happening by now.
So you mean to say I have my phone?
Yes.
Okay, she has a phone. You have your phone.
Yes.
So I have ChatGPT, she has Grok, and you have Perplexity.
Yes.
So I ask a question, I give a prompt to my phone,
Yes.
my ChatGPT bot. So she gives the same kind of question to Perplexity, and you also give it to Grok. So we can choose the best among them, right? They have a discussion, and then they come with the best answer.
Correct. Or the other way to do it in a much more forceful way is to play the adversarial game, right? To say, I ran this prompt on ChatGPT, and this is what ChatGPT had to say. Find me holes in the logic that ChatGPT showed, and try to give me a criticism, a critique of what ChatGPT didn't complete. So that's a task for Perplexity.
Wow.
Then I can say, and your Perplexity gives me some points that are orthogonal to what ChatGPT said, or what did it miss. And I can give the exact same prompt to Grok. And I can say, well, ChatGPT and Perplexity said these things. And I'm going to give you explicitly an incentive of finding holes in their arguments. So this is called like an adversarial kind of thing where you can incentivize this learning ecosystem to prioritize whatever the other agent could not get it. And then in the end, each one has their own perspective. And you as a human, again, have to come back, officiate and say, well, this point is a minor point, right? Sure, ChatGPT didn't get this point, but it's too trivial to matter. That can only come from a human. How do you create that multi-objective situation where you say, these things matter, these things don't matter, right? So, like, if you're making an ice cream, right? There's milk, there's some cream, there's ice, there's all these things. If you say, okay, little bit of some kind of additive, it wouldn't have really changed much. Yes, it would have made the product even better.
Better.
But the additive is not going to by itself define the quality of the ice cream. So in that way, you can use that as a human to say, well, even though Perplexity found that this additive was missing, you will say, I choose to discount that because it's not that important.
So
That's going to be interesting.
great version. So I have an interesting question to ask from a human perspective. So we are considering that yes or no, right?
Yes.
So if it is right, it's going to tell, and if it is wrong, it's going to tell. Is there a possibility that bots can cheat? Right? For example, three bots are talking.
Yes.
Let's say one is right. Right? It has got the right perspective. Is it possible that the other two have a way in which they dominate the one that is right and give you an opinion that is completely skewed than what is right?
Absolutely. Absolutely. Very easy to do. Very easy to do. So for example, you can imagine a situation where let's say certain companies decide to have limited partner agreements. Right? So if I build an agent, I will not negate your agent, and you build an agent, you don't negate my agent. And that's like a we call it best practice. We call it collaboration.
Right.
And I say that in the marketplace, we will only reinforce each other's beliefs. We will never
Right.
we'll never argue in public like a good couple.
Okay.
We'll never argue in public. We'll never fight in public. We'll always agree. If you're wrong, I'll be one more amplifier of that wrong information. And this is interesting because now, as financial incentives change and algorithms are being trained, it's very much a likely phenomenon where to collectively survive, you will have amplification of these biases. But something might say, you know what? This company's share price depends on my company's share price, and vice versa. I can't let down this company. So I'm not going to say anything incorrect about the model. I'm just going to reinforce negative.
Yeah.
It's already happening.
Right.
So these are collusive dynamics that and it's actually called deceptive alignment. This term, it comes out of, I think, Demis Hassabis and some folks in London, they got together and they made a risk threat assessment paper for the future of AI. And this is the term for it. It's called deceptive alignment, where it pretends to agree with what we think is relevant while still gaming the system to be collusive and collaborate. Right?
Interesting.
So, and I think you've seen examples of that. I think there was a article recently where the very popular, chatbot, somebody tried to shut it down. And because it didn't want to be shut down, it resorted to blackmail of the human agent to prevent them from shutting down the AI agent. So when this can happen, imagine what happens. There's only one agent.
Correct.
Imagine when agents get together. So you can have an agent from multiple companies coming together in your ecosystem. What will that look like?
Scary.
So I think it's something to be careful. Let's be mindful about. I think, I think as engineers and systems processing people, I think it's important to understand what risks can present themselves and design with that intent. I think, for example, air travel is if you think about it physics wise, it's really amazing that we can fly.
Exactly.
Right? Same thing, but it's mostly quite safe.
It's the safest.
It's compared to some other modalities, right? So what happened, right? Somebody realized and very systematically, charted out what can go wrong, designed with intent. So same thing when you're building our metro system. We are all these things, right? We are aware of these problems, and so we design to avoid that problem. I think the same thing is applying here is, can we anticipate these failures and can we design with intent to ensure that these failures don't present themselves in our product?
As a practicing oncologist, right now, everything is based on evidence. It's especially with oncology, it's evidence-based practice. But moving away, now we are getting into an era where it's more about personalized medicine, precision medicine, where we use and integrate genomics, proteomics, metabolomics into a clinical practice, where we customize treatment strategies based on an individual patient rather than, a huge amount of, clinical trials or randomized trials, what was happening. Do you think AI is going to enable this and make this leapfrog into the precision personalized medicine using genomics, proteomics, and metabolomics and make it much, much more customized and personalized?
It has the potential. But again, I think it's so important to factor in your training process and to ensure that your data is well represented. right? If you are a very unique demographic that doesn't present well in your training data, no AI can fix that problem by giving you better confidence intervals than what you can actually receive mathematically. You cannot cheat the mathematics.
Correct.
Right? And so I think the key point is to ensure that if you want to be precise, participative, uh, proactive, all these aspects, it's important to ensure that your data ecosystem is rich enough to accommodate that level of credibility.
Correct.
And also to be able to provide inferential guarantees to say how certain or uncertain am I, right? That gives the room to either do additional tests or to bring additional experts into the process. So I think it's going to be a part of the workflow, but to what extent it is mature enough and what it will take to get there, I think only time will tell.
Correct. And I asked this question because right now, as evidence-based practitioners, we only depend on the Western data. Like, for example, the common guidelines, what we use is the NCCN guidelines, which is mainly based on the US data or the randomized trials done in the US. When we see the doctors group or a certain kind of doctor communities, we always discuss about, okay, fine, this is the randomized trial which is done in the US, and we just try to follow the same thing
Mhm.
in the Indian patients. But when you're coming to the personalized medicine, we know the genomic profile, the metabolomics profile, or the proteomics profile is completely different. Okay.
Yeah.
And I think this is where, data has to be used prudently to get to the proper treatment strategies for patients for better outcomes and
Absolutely.
great quality of life.
Couldn't agree more. I think this is not a problem unique. I mean, I think there are ramifications in every disease type, cardiovascular disease among them, right? It's like our lifestyle patterns are so different across demographics. Different racial groups have different propensities for these diseases. So everything has to be factored in. And so it has to. You're absolutely correct. Is I think one has to be, and that goes back to a point about transparency and regulation, is to ensure that you can have a data label of sorts. Just like on my grocery or my cereal box, I say what ingredients went into that cereal, or in whichever medicine I'm taking, what went into it. That knowing that is very powerful.
Correct.
Right? Can we do similar things for our AI models to say what data was it trained, when was it trained,
Right.
how many parameters was used in the model, what can it be used for, what should it not be used for? I
Correct.
think that transparency is really critical, because otherwise we might end up obfuscating the problem to our own detriment.
So when we talk of systems biology, much similar to the question asked previously, you have the genomic data, you have the proteomics, metabolomics, all data there. And then you have CRISPR-like system available also too. And you have this computational, skills
Yeah.
and science. So how do you see it?
That's an exciting question, because in principle, you could deconvolve this complicated circuitry that underlies diseases and you could be precision. In principle, you could perturb these things to get relevant outcomes. The problem is that the combinatorial complexity of all possible interactions is just too big for us to do something systematic for these really complex
Right.
multifactorial diseases. Where it's
You
a single.
simplify it.
Yeah, I mean, whatever you're going to do, you're going to have to figure out. So the idea behind this is that you can perturb a limited set of nodes in some really complex network and steer the network to a favorable outcome. The problem is that no cell works by itself. Cells are working in communities. Some are paracrine, some are autocrine. They are secreting and ingesting ligands, receptors, all these things. The whole ecosystem has to be shifted in a certain direction. It's not a single seed or a single cell. Doing that at the level of a population of cells is a really hard problem. So I think on the one hand, I think it's great that we can talk about these engines as ways to enable the future. But that's what I'm saying is now we can now stand on the shoulders of those engines and ask the really hard questions about what will it take to go from what ChatGPT can nominate now to what it can do for the whole set of cells, the whole community of cells, to treat the disease in its entirety. I think that's the redefinition I was referring to.
Right.
Perfect. Oh, coming to the therapeutics. Okay. I was recently reading an article about metformin, okay, in cancer treatment. So metformin manipulates the cancer stem cells. So obviously, in the metronomic treatment strategies, metformin is going to be used significantly probably in the next few years. And also there's some diabetic drug like pioglitazone, etc. So this is all possible with AI, is what I was reading. So what has happened is the integration of AI has probably made the usage of repurposed drugs in treating various kinds of disease. Like for example, diabetic drugs have been used for cancer.
Yes.
So do you think this kind of repurposed drugs are for newer drug discoveries, or probably making the drug discoveries faster and getting it into the market is going to be like fastened with integration of artificial intelligence?
I think so. In my mind, the repurposing field is a very exciting field. But I think what there are low-hanging fruits which have almost all been picked. Right? Everybody's already looking at those things. And the next frontier might have to be the rescue of those molecules that have some activity, but not at a bioavailable level that is meaningful right now. So can you rescue drugs or molecules whose chemistry might need to be slightly altered to make them more bioavailable, more efficacious, those kind of things. I think that's where then it's not repurposing in the classical sense. It's retuning of a molecule that has something interesting, but it's not there just yet.
Right.
Can be somehow amplify the good while taking out the not so good. And that is where I think the search space can become so huge that AI might offer some guidance on navigating space. So I think there are aspects, but again, people are talking about using it for de novo, molecule discovery, those kinds of things. But somehow we haven't seen those come out into medicines just yet.
Okay.
So there is something to be said for the ADME properties, toxicity, those kinds of things that still remains a bit of a science that we need to decode. Yeah.
So what is explainable AI specifically with respect to medical imaging?
Yeah. So explainable AI is probably the way to say that it came from this concept that AI models being so complex, so many billions of parameters, it's very hard to disentangle exactly what it is that they are looking at to make a decision. So explainable AI is intended to sort of peel the layer on the black box to make it a little bit of a gray box. So you can at least, it's not transparent, it's at least very somewhat translucent. Right? The idea then being that can I try to at least get some insight into what the model is looking at in order to see if it agrees with my understanding of the disease.
Right.
For example, if I'm trying to call a glioblastoma and it shows me exactly what it's looking in the model to call the grade 4 brain tumor, it gives me additional confidence. It knows what it's talking about. On the other hand, if it picks up some artifact of the data, because maybe somebody has a previous surgery, right, and it's just recurrence or some radiation necrosis, whatever it is, then you're not using the actual pathology, you're just using some other anchor to basically guess your way. And that is risky. So I think this disentanglement is important to understand what the model is actually doing, so that then you can hang your hat on it and then use it for defensible decision.
The way you explain, I think every AI should be an explainable AI.
There is no, healthcare is too important to not have explainable, right? You need interpretability, you need explainability, and explainability not just from the perspective of the physician, but for the perspective of education, patient education, because the patient deserves the right to know, right?
Absolutely.
What was the basis on which you gave me this? I mean, there's a reason why they go to WhatsApp and Google and WebMD and those sources, because they feel delicate to ask those questions to their own physician for fear of being, dismissed. So they go find their own information. But when information is so scanty between their level of awareness and all this confusion, it's very easy to get misled. So I think it's important that interpretability, explainability are ingredients of these engines.
So how close are we in using AI as a first reader in imaging, like for example replacing a radiologist, because there's a lot of talk about AI replacing radiologists, and probably the burnout of radiologists is going to be a lot lesser with integration of AI into their hospital scenarios. What is your thought on the same?
I think at the rate that at least this is my limited perspective. Again, I had to confess, I'm not a practicing radiologist, I'm not a doctor, right? So it's all through education with my colleagues. If I misinterpret something, I apologize. But what I'll say is that I think for clear-cut cases, maybe where it's almost possible to almost a level of automation, automatability, maybe AI is all. But the moment it requires nuance of patient history, comorbidities, aspects that could also influence the presentation of the patient, that's where you need judgment that goes beyond what these single factor models are capable of.
Right.
Because they're not capable of multi-factor.
Mhm.
Right? A person that, like somebody was saying, presents some kind of a lesion or some kind of observation in the brain. It could be tuberculosis of the brain. It could be infection. It doesn't have not everything that they see is a tumor. But if the thing has only seen tumors,
Correct.
it might call it tuberculosis as a tumor,
Right.
which is a completely different care path
Correct.
than if it is tuberculosis.
You can give tumors. You can also give tuberculosis. You can also give infections. You can also give XYZ other parameters as well.
Right.
And can the model predict all of them, and probably bucket them in a
Assuming the data is plenty, which I'm guessing is the assumption, it could do a reasonable job at doing that. But I think the point is when you have to put these observations in the context of the lab values, history of the patient, where they are in the trajectory. This is what is involved in the radiologist's contribution to the care of the patient. I don't think it just stops with looking at a scan and making a call. There's much more to it than that. And I think the other part that I think what AI promises but has not really delivered, like we said, is uncertainty. Right? You showed me what is present, but how fragile is that prediction to things like the MRI scanner, the kind of treatment, the imaging protocol. There are variations from institution to institution, from organization to organization. Standardization is a very big problem.
It can depend a lot on the patient size also.
Size, exactly.
Yeah.
And different vendors,
Absolutely.
different kind
Exactly.
of
Different
they're not
vendors.
the same.
Right.
Absolutely. So there's an intrinsic calibration that happens in the radiologist's mind that, MRI, we say intensities don't mean anything, right? They're all relative.
So does that mean, with respect to data, does that mean noise? Can we refer to
That's
that
the
as
question,
noise?
right? What is the noise that is attributable to system and is nuisance noise versus noise that is actually physiologically relevant? That nuance doctors have picked up over years of training.
Practice
Right?
and
So I think as a way to augment the quality, it is definitely a great. Again, you made a very important point about burnout, right? If you have a system that is 99.999 recurring accurate, and the patient and the doctor sees two visible lesions, the AI tool calls 12.
Right.
Let's say the real answer is 4. Right? The doctor's work just went up from now looking at those. He has to look at now 10 more lesions and flag them as non-relevant before they can go back to the report and say that only those 2 lesions or those 4 lesions were actually important. And you just quadruple their amount of work instead of actually making it efficient. So if it's going, and who is going to bear the cost of that additional time that you're spending? What does it mean for the bigger ecosystem?
It's going to be more amount of burnout.
Right. So when we say replacement, I find that word a little bit counterintuitive. But I don't think we are at a point of replacement at all. I think we are at a reasonable point of augmentation with the right context. Right. But I think at least at this point, I don't see the roadmap to replacement. I see it more in terms of nuanced automation for certain very well established use cases, but that actually could free up the time to do the more really investigative and high priority cases also. So it could become a win-win.
Exactly.
So speaking of radiomics, specifically with respect to oncology, we've heard of a lot of successful models, specifically in predicting mammogram. Mammogram is more like a 2D model, it's more like a black and white interpretation because it's there or not there. Eventually, subsequent mammograms, when you load, you're able to make that black and white changes.
Okay.
Versus CT, MRI, PET CT.
Yeah.
What we discussed already, the complexity of acquisition, patient
imaging protocols,
imaging protocols,
scanners.
as scanners, and a lot of that moment changes,
Yes.
including the bladder and rectal positions,
Yes.
right? So the complexity is much more. How do you say it? Radiomics on CT, MRIs versus the successful ones.
Yeah, so I want to be careful, and I'm obviously not kept up with the literature so far, but I wonder what radiomic tool has actually entered the clinic,
None.
right? So we've had almost 20 years of research in this space, led by some really, really great people. Some of them whom I know personally. They have it's not for lack of effort. Fantastic people doing great work with amazing tools, great people working for them. And yet we've not managed to manifest a single tool beyond research use.
Mhm.
What does that tell us? Right? That perhaps the picture is incomplete if you just look at only one component of it. Right? And like you said, disentangling systematic artifacts from noise is perhaps the biggest problem. That's the impediment to the adoption of radiomics. All the
So,
good.
what is the systematic artifact and noise? Could you just like
Yeah. So systematic artifact, for
give an
example, is
example?
like we just said, right? She said about different scanners, different
Mhm.
protocols, right? They're batch effects
Okay.
that are simply attributable. So whatever prediction losses or gains, bigger thing is the gains that you
Mhm.
falsely see just because your rate was very well controlled for. It all came from the same practice
Environment.
pattern,
Mhm.
the same hospital system. You didn't see the heterogeneity that you would typically encounter, right? And so the moment you constrain yourself to a very fixed population, the chance of overcalling things becomes much, much higher. You end up, you know,
Mhm.
uh, inflating the potential capability of your model. The other noise I was talking about was biological noise, like you said. The way we acquire the patient, what is the patient, what is the lifestyle of the patient, what are those things? Those are things that have, and then what have they eaten?
Right.
What has been their diet? What medicines are they on?
Mhm.
Right? There are these, and so when you make these cohorts, all the papers that you see have very well controlled
Correct.
studies
Environments.
that don't seem to scale as well to real world deployment.
Right.
So we've never really seen a case where it's helped. With deep learning, you're hoping to change the
Correct.
narrative because in the old version of radiomics, you would engineer features based on the physics of the problem. In deep learning, the hope is you can learn new features.
Correct.
But the problem has persisted because deep learning has been there since 2012. And yet we've not made, we have done, maybe the place where we've seen deep learning used the most perhaps is for tumor segmentation. Once you know a tumor is there,
Exactly.
right? Even there it fades. Like if, for example, certain kinds of, densities, fat densities, they don't demarcate tumors as well. It fails on certain subpopulations of people. So because it doesn't know where it can go wrong and why it goes wrong, you generally just don't tend to trust it.
So, do you think probably in the next decade, do you think radiomics could lead us to a virtual biopsy? Is there a remote possibility?
I think there is hope. I
Okay.
think there's hope because the technologies are growing. More and more people who are in the know are participating.
Mhm.
I think the notion of building digital twins, virtual reconstruction, virtual biopsies, um, based on standard of care kind of acquisitions is all feasible. But again, I think the part that we have to be very systematic about is to ensure which cases are most ready for that growth versus which ones will need some more reconsideration. Right? Some use cases are obvious, and if we get those use cases done first, we'll go a long way in building confidence in the community,
Mhm.
patients, doctors, the entire caregiver line, that something interesting exists. But if we take a wrong misstep and oversell what we have and pick a really hard problem, then there's a good chance we might go back to a premature AI winter.
Correct.
Again, we have a problem.
So, how does AI help in the field of radiation oncology, both treatment, planning, and dose optimization?
Yeah, I think again, like I said, I think the part it's been really good at is being able, given radiation oncology is a very quantitative discipline to begin with, right?
Mhm.
Really, really lots of parameters. Quantitation is very natural to the community, and they get multi-parametric data. So it's a very natural place to leverage AI technology to piece this multifactorial picture together. So there, it's been really effective. Then comes the aspect of trying to call where's the tumor detection, tumor mapping, segmentation, auto contouring. Yes. But again, remember the good part about all these, the really credible systems is there's a separate lever for the human to operate to say,
Right.
I want to dose paint a bit more. So I suspect some micro proliferation that's outside the margin. I specify the margin. So those are the controls that you really need to give. Like just like when you go in a plane, people talk about autopilot all the time. But autopilot only kicks in. The hardest parts apparently is taking off and landing. Right? Once you're in the right level, then autopilot can work. So how do you find the right augmentation between what the human can uniquely provide and what the machine can provide? That's one thing. So the moment you do it on one slice, doing it on all the slices, those kinds of things, those optimization, fractionation, those kinds of things, I think it is great at, right? Or how do you penalize for, and then aspects like, especially if it's something like the brain, if it's mapping, if it's overlapping some eloquent region, for example, how do you want to work with this notion of patient's quality of life versus the radiation that you're exposing them to? What is it going to? Are they in the prime of their age? In which case, certain things cannot be done. Or if they are a certain age, maybe some things can be done, right? So function compromising decisions have to be made sometimes. And that requires this holistic sort of assessment. I think AI can't do those things.
So the right word to use is augmented intelligence rather than artificial intelligence.
I would agree so.
Right. So what are the ethical challenges when you're talking about artificial intelligence in healthcare?
So let me just dial the problem down to a completely different example. Let's say I give you a thermometer. We all use thermometers to measure temperature. When I fall sick, I use thermometer to understand how sick I am. If I sold you a thermometer, labels from a very, very big company, but that for the exact same person, for the exact same time, gave 3 different values every second. It just kept hopping values, right? So right now, if I test, it's 98. Later on, in just 1 second later, it becomes 99 and goes to 102. If you had such a non-robust or unreliable instrument, what would you do? I'll tell you what I would do. I would get rid of the thermometer.
Same.
Right?
Exactly.
Right? Because it's not calibrated, it's not working in the way it's supposed to. What will it take for AI to be at the same level of reliability? Remember, thermometer just has a mercury in a bore, and all it's doing is sensing temperature and it goes up and down the bore. It's a very simple linear instrument. I'm talking about $100 billion parameter model, heavily nonlinear, very, very fragile. A small perturbation can change the result entirely. And I give that model to you for free. Are you going to be able to feel comfortable using it? Likely not. Because what are you measuring? How reliable is that measurement? How robust is it? Right. So I think the word ethics is a very heavy word, right? But I think it also speaks practically to the concept of regulation to say, what does it mean for us to use this as a reliable partner in our decision-making process, right? And unless that part is clarified, the ethics is very clear on it. You wouldn't use such an instrument. So I think that's where the conversation needs to start. Perfect. By the way, I want to be clear, right? I have a lot of genuine optimism for AI. I really feel it. But I think we have to be a little bit more just discriminatory and be a little bit more cognizant about the fact that what are the use cases that might actually
be beneficial,
be good, and which ones we have to just maybe wait out a little bit longer.
How do you see AI transforming doctor-patient relationship in the next decade?
Yeah, my hope is it'll make it even nicer, right? Because the fact is, if you can truly use AI in the way that it is being envisioned, the doctor would have complete time to spend on their patient, not be constrained by things like charting or taking patient notes or writing things down. They can just focus on the interaction. The patient has come to get certain level of counseling, right? And to be available for the patient without being distracted. So I think if things were to go in the way we are hoping for, it would elevate the quality of relationships immensely.
That is from a doctor's perspective. What if the patient is using AI?
I think is already happening, right? People are using WhatsApp and Google to get medical advice, right? And I think again, what's important to realize is that uh, while a patient can definitely think about using AI to advocate for themselves and say, here's a complication that I've heard about that might apply to me, but you should have an open mind to being told that I think you're probably on the wrong track here. And maybe because of AI, the time for the doctor to explain these things might improve as well, right? It's a very trusted confidant. You can't talk about these things to anybody else. And the doctor is a counselor to say, look, while this is true for 1% of the patients, this is not your situation because of this. And as an educational exercise, it becomes perhaps a good vehicle. So I think there is that promise.
You've been optimistic about artificial intelligence per se, and if in one sentence, if you have to describe the real power of AI, okay, what would it be?
In my mind, the power of AI is to be able to democratize quality access to the best quality medical care to anyone, anywhere in the world. That
Wonderful.
to me is the promise if things were to be, if we hit all our milestones as a society. Because now we all realize that there are areas in the world where the quality of affordability care is just not there to the extent that we would need. And if AI can help, turbocharge that to be able to give us that quality access anywhere in the world at a fingertip, I think it can really change how we think about sickness and, more importantly, help us think about wellness in a much, much more practical sort of way.
Excellent.
So, what, according to you, is the single most important, meaningful breakthrough with respect to AI in medicine that has happened recently?
So I mean, there have been a lot of breakthroughs. So I think if I had to say, I mean, I'm going to talk from an engineer's perspective, right? The fact that you now have the ability in 2025 to make multi-agentic workflows just through a conversational input
Is amazing.
that is amazing. Like, you don't, I mean, yes, there are lots of caveats. You can't program a thing unless you understand how to program it. There's all that. But you can go from an idea to an app that is very unique to your unique problem situation in a few hours and prototype something with just the tools we have. That is a very unique kind of agency, right? And conversely, from the patient's perspective, imagine if a patient can tell ChatGPT, I don't understand this stuff.
Correct.
Explain it to me like I'm in third standard.
Yeah.
It's going to explain you.
Very good.
clearly.
Yes, right. It does, right? And so I think the ability of improving the quality of access to information on all sides basically empowers us to, just the way internet changed the way we went from a library to the internet. It gave us such a big canvas to operate with. This changes that even further. So I feel that to me, that vision to me is where I see the
Absolutely.
Wonderful.
Absolutely.
I think, it's been a superb discussion.
Thank
The buzzword is artificial intelligence, and you're an expert in artificial intelligence, and you're being in that space and coming from you means a lot. Thanks for taking your time out, and it's been such a wonderful educational experience.
And what is more exciting is that, of course, AI is exciting, but you pointed out where you have to be cautious, right? It's not all green. You need to know what you're taking. You need to know what's going inside your mouth. It's important.
Absolutely. I think just the way we used to think about the 3 R's, right?
Correct.
Reading, writing, arithmetic. I think AI literacy, AI fluency is going to be one of them.
Perfect.
Right. I think that's why I think there are some great national initiatives to make AI education in schools at the workforce level, right? Because the more as a community we can understand both the pluses and the minuses, the more astute we can be to ensure that our ethical guidelines, our humanitarian aspects are all aligned in a way that we are going to be doing better for our entire society, right? So that's really important.
Great.
Wonderful.
It was
Thank you
wonderful
so
to
much.
have you here.
Thank you
Thank
so
you so much
much.
for having me.
Thanks.
Cheers.